Okay, so good morning everyone, and welcome back to Summer Course 2023. And today we will have several topics that will be delivered by overseas and national speakers that will discuss about two main topics. The first one is about the rare diseases, focus on genetic disorders, and for the afternoon sessions you will join the lectures that discuss about the aging. For the first panel there will be 5 speakers from national and also from overseas speakers, and I would like to remind you, don't forget to check your log because I already put one assignment for you in your log, and I just want to give some information also. For Sunday November 12th, make sure you bring your t-shirt, your summer course t-shirts for the outbound activities. Okay, we will start the outbound activity around at 8 a.m. in a Seow residency. So the group in Seow, is there any group from Seow? Okay, so you don't need to go far away because the outbound place is in Seow, maybe around 1 kilometer from your dorm. And then for the next weeks, you also have the quiz, post-test quiz, start from Monday until Sunday. So make sure you done your quiz because that will be one of the indicator to get the certificate and also the course achievement. Okay, so let's start with the first panel from the morning sessions that talk about the rare diseases, especially for a genetic disorder. And this panel will be moderated by one of our lecturers from Department of Dermatology and Venereology, Faculty of Medicine, Public Health and Nursing, Universitas Mada, Dr. Dyah Mira Oktarina, Ph.D, Sp.KK consultant. And let's invite Dr. Dyah Mira.
Good morning. Assalamualaikum warahmatullahi wabarakatuh. Dear professors, doctors, colleagues, students, and all the participants, thank you for joining the Summer Course 2023 on Interprofessional Healthcare, Future of Healthcare, Leapfrogging Innovation Through Precision Medicine. I'm honored to be the moderator of the second panel on the second day with our 5 outstanding speakers. There will be 5 outstanding presentations divided into 2 sessions. So the first session will be about management of rare diseases in Indonesia from Professor Dr. Damayanti, Rusli Sjarif, pediatrician consultant from Division Pediatric Nutrition and Metabolic Diseases, Universitas Indonesia. The second talk is about genetic skin diseases from Professor Dr. Retno Danarti, dermatologist consultant from Universitas Gadjah Mada, and the third talk about precision medicine in Duchenne muscular dystrophy from by Dr. Kristy, Iskandar, pediatrician consultant, M.Sc, Ph.D from Universitas Gadjah Mada. There will be a short break after the 3 talks, and will be followed with 2 talks. The first talk is about the National Precision Medicine Program Singapore by Shih, Ph.D. And the last but not at least, the talk about evidence synthesis and precision medicine in tackling rare disease insights from Malaysia from Assistant Professor Teguh, Haryo, Sasongko, M.D, Ph.D from International Medical University. We will proceed to the first talk. I would like to welcome Professor Dr. Damayanti Rusli Sjarif, pediatrician consultant. Good morning, Prof. Damayanti. Thank you for being with us. And on the screen, we will see the bio sketch of Professor Damayanti, please. Damayanti. 30 minutes is yours. Thank you.
Can you hear my, no, I think you can hear my voice here. Thank you, Madam Moderator. Good morning, everyone. I think today I would like to share with you what I do for managing rare disease in Indonesia. So my topic, my presentation, including this rare disease. But when you look, when I first began with this, I think looked like impossible. But at least now, step by step, we can treat the patient better. I think this is my message to you. Thank you for your attention.
Thank you very much, Prof. Damayanti, for the interesting and outstanding presentation. You can be seated. I will invite all the speakers in the end of the session for discussion. We will proceed to the next presentation. For the second talk, I will welcome Professor Dr. Med. Dr. Retno Danarti, dermatologist consultant. Good morning, Prof. Retno Danarti. Thank you for being with us this morning. On the screen is the bio sketch of Prof. Retno Danarti. I will welcome Prof. Retno Danarti to give the talk for 30 minutes. The time is yours.
Yeah, thank you very much, Dr. Mira, for the very nice introduction. Dear professors, doctors, and students, first I would like to thank to the organizing committee to invite me to share our clinical cases in dermatology polyclinic in Sarjito Hospital. The topic I would like to share with you is about genetic skin diseases, diagnosis approach and management. Sorry. Yeah, I would like to divide my topic today into three parts. The first one is definition of genetic skin diseases or genodermatosis, and the second one is about diagnosis approach on genetic skin diseases and management in genetic skin diseases. The example is in epidermolysis bullosa and ILVEN. As we know that the genetic skin diseases is a very rare disease. My supervisor in Germany, Professor Rudolf Hapler, always said that skin cutaneous is a genetic window. From the skin, we can see many patterns of mosaic, and this is the unique accessible organs in approximately 1/3 of all hereditary disorders show characteristic cutaneous findings. Genetic skin diseases or the genodermatosis is a spectrum of rare and very rare hereditary skin disorders which occur as an isolated phenomenon. For example, only the nevus flammeus or port wine stain or port wine birthmarks, and sometimes also affect multi-system organs that causing significant mortality and morbidity. The diagnosis is challenging because the very rarity of disease and diversity and sometimes overlapping or heterogeneous phenotypes and huge amount of new information, many mutations found, and complicated nomenclature and classifications. The genodermatosis can be recognized at birth or during early infancy. The identification of their skin findings is very important. Genetic skin disease, as I mentioned before, is under-recognized or misdiagnosed frequently. The the delayed diagnosis is inevitable. Distance to the health facilities is also the problems to bring the patient to the hospital, and the lack of awareness with the prevalent perception of local myths linked to these conditions. The lack of diagnostic tools and therapeutic approach is also one of the problems. For example, in Sturge-Weber syndrome, the left picture is a girl. She came to us in 3 months of old, and we can diagnose her with the syndrome, Port-Weinstein, and leptomeningeal angiomatosis. She has also seizures, and we can prevent the glaucoma because we make an early diagnosis, and we refer to the ophthalmologist, and the ophthalmologist can diagnose a glaucoma, and it can be treated, and the eyes is normal. Unfortunately, for the second picture, the girl come to us with one of her eyes, the right eye is blind with no visus. Because of the late diagnosis, she come to the doctor in primary healthcare, and the doctor said no problems, that is all only nevus, it only cosmetic problems, and actually we can do the refer to the hospital and to the ophthalmologist, and the ophthalmologist can make a diagnosis with glaucoma and can prevent the blind. The third ladies have decreased visus. Unfortunately, it's not blind because we can make an early diagnosis, not from infancy, but we can prevent the blinding. How to approach to the diagnosis of genetic skin diseases? There are red flags in diagnosis of skin disease for genodermatosis. Some cutaneous findings represent important clues for the recognition of hereditary skin disorders or syndrome. I have mentioned before that the facial Port-Weinstein at birth or on trigeminal dermatoma frequently associated with Sturge-Weber syndrome, nevus flammeus, and angiomatosis and glaucoma. Clinicians should be aware of a substantial age-dependent phenotypic shift that may occur over the natural course of any given disorders. For example, in tuberous sclerosis, Prof. Teguh is an expert for the tuberous sclerosis. Sometimes the tuberous sclerosis can be diagnosed in early infancy, in birth, after birth, because of we can see the macule or patch, hypopigmented patch, and we can make an early diagnosis. And we should ask the patient or family for clinical picture from infancy and early childhood is very helpful for narrowing the differential diagnosis. Yeah, this is our patient about the tuberous sclerosis. From birth, he has hypopigmented patches, edge-leaf macules, and in childhood, the boy. This is the same. The three pictures are the same patients, and he comes to us in early childhood. He had the Chagrin patch or connective tissue nevi, and the facial we can show the facial angiofibrome, and in teenager we can see the tumor in periungual. This is a periungual fibrome. The step 2 to diagnose genetic skin disease is obtaining a thorough medical history. A 3-generation family history or pedigree is currently considered the gold standard for clinical practice. If possible, examine first and second degree relatives, and we should ask for the clinical picture and medical documents. And sometimes we should repeating the question to discover or forgotten information. In anamnesis, we should ask the relationship of relative, sex of relative, age of year or birth, and so on. And don't forget to take family history in pedigree. And we should remember that a negative family history doesn't rule out genetic skin disorders, because many genodermatosis occurs sporadically as a result of new mutations or may appear to be sporadic. The step 3 is perform a complete physical examination, including hair, nail, teeth, genital, and oral mucosa. Look for extracutaneous manifestation. Identification of additional, sometimes minor changes of the skin and appendages are helpful in narrowing the differential diagnosis, and sometimes even in determining the final diagnosis. Congenital anomalies and extracutaneous findings might point to a specific diagnosis, and further laboratory and or imaging workup should be adapted accordingly. The red flag in genodermatosis, I show you only 3 red flags, because the 4, 5, and 6 maybe in the next meeting. To determine the exact phenotype, early recognition of hallmark skin manifestations of hereditary disorders is very important. For example, in tuberous sclerosis, we can find a macula as leaf, and in Stutzweber syndrome, we can see the birthmark nevus in form of Port-Weinstein on nevus or nevus flammeus. And the second is look for pattern. What about skin lesion, pedigree, and etc. And do a search in OMIM. OMIM is Online Mendelian Inheritance in Man database for genetic diseases. And when we cannot find the syndrome in OMIM, then ask the expert. Maybe because this is the first one, the first diagnosis in genetic skin diseases. And then determine the exact phenotype, taking history, examination of skin lesion, and complete the physical examination. And look for pattern. For example, we have 5 patterns of skin mosaicism. The first is Blaschko lines, and the second is checkerboard pattern or block-like pattern or flag-like pattern. The third pattern is phyloid pattern and patchy pattern without midline separation, and the lateralization pattern. We should also look at the primary lesion, secondary, what about the color, configuration, area of body involved, mosaic, the autosomal dominant, autosomal recessive or X-linked diseases. And then we do a search in PubMed or OMIM and ask the expert. Case 1. We should determine the exact phenotype. The baby had limb abnormalities, and the skin showed ichthyosis or psoriasis-like lesion, And we can see here the pattern. The pattern is in lateralization pattern. And this is the same girls as she come to us. This is 4 months old, and this is 3 years old. The skin nevi showing Blaschko lines, and the lateralization pattern become disappeared and with lines of Blaschko. And look for pattern, for example, skin lesion, pedigree. We can see here the pattern in lateralization pattern. And do a search, PubMed OMIM, we write here limb abnormalities and ichthyosis-like and lateralization pattern. We found diagnosis is congenital hemidysplasia with ichthyosiform erythroderma or ichthyosiform nevus and limb defect. Child syndrome, congenital hemidysplasia, ichthyosiform nevus and limb defect is an X-linked dominant male lethal trait. It occurs in a girl because when occurs in male, it is a abortus. It caused by mutation in NSDHL gene. The clinical picture is inflammatory nevus, ipsilateral extremity anomaly in the form of hypoplasia or bone aplasia, and it could be accompanied with ipsilateral visceral defect or neurologic defect. This is our publication about child syndrome. The case to determine the exact phenotype. This is a family with congenital symmetrical cornification or congenital symmetrical hyperkeratosis in palms and soles. It is transgressive and ichthyotic changes. Look for pattern. It is symmetric and transgressive, and we can see the pedigree here. Do a search in PubMed, we write a palmoplantar keratoderma and transgressive. And the disease we found is Maldemelida, is keratosis palmoplantaris transgrediens. It is an autosomal recessive form of palmoplantar keratoderma and clinically characterized by sharp demarcated erythema, hyperkeratosis of the palms and soles that progress with age or transgredients and extend to the dorsal aspect of the hands and feet. Frequently present with constricted bands and with a progressive clinical course through the patient's life. This is our publication about Maldemelida. The next case is the baby has absence of all nails. He also has seizure and deafness. The pattern I cannot find, and we do a search with we write seizures and absence of nails and deafness. The syndrome is Door syndrome. Consists of deafness, onychodystrophy, osteodystrophy, mental retardation, and seizures. This is a very rare multi-system genetic disorders that mainly characterized by sensory neural deafness, shortened terminal balance, intellectual deficit, and seizures. It is caused by mutation in TBC1T24. This is our publication about Door syndrome. And the third topic is management in genetic skin diseases. I would like to disease, for example, is epidermolysis bullosa and inflammatory linear verrucous epidermal nevi. What is epidermolysis epidermolysis bullosa. Epidermolysis bullosa is a very rare disease. It is a painful genetic skin condition that causes the skin to slightest tear and blisters at the slightest touch. It is genetic, and the skin is fragile as a butterfly wing, and the layers of skin tear and blisters easily, and it can affect internal organs that affect also estimated 500,000 people worldwide, and this is not contagious, and unfortunately until now there is no cure for the disease. There are consensus reclassification of inherited EB. The classical types of EB, there are 4 classical types. Is epidermolysis bullosa simplex, junctional EB, dystrophic EB, and Kindler EB. And no, the disorders with skin fragility is also included in the reclassification. It is consists of peeling skin disorders, erosive disorders, and so on. This is a clinical example of our EB patient with erosion and all over the body. Depend on the classification, and oral mucosa abnormality, and sometimes with ulcer and painful erosion. The girl come to us in 23 years of age, and she has erosion on the philtrum and ears fault, and some erosion in all over the body with the nail abnormalities. The girls have one younger brother with erosion in ear fault and in all over the body, but the brother had ulcer in plantar. The picture in right side is after we have treated with wound management, and this is epidermolysis bullosa, and we do whole exome sequencing, and the girl and the younger brother have a mutation. And how is the management of the epidermolysis bullosa? It is a comprehensive approach because the patient with epidermolysis bullosa had many problems. For example, chronic wounds and infection, chronic pain, chronic itching, psychological and social stigma, and lack of self-care. We try to do the NCCS modified with non-cultural cell spray. We take a donor sample from the left thigh, and we do a spray, and this is the girl, the first come, and this is the 3 weeks and 14 weeks, I forget, 4 weeks and 14 weeks, and unfortunately, in 15 weeks, the erosion came again. The second case about the medication is inflammatory linear verrucous epidermal nevus, or ILVEN. It is a rare disorder of unknown etiology. This affects children at birth or in the first few years of life. Consists of inflamed, red, thickened, scaly, itchy, and often painful visual skin, and the disease is always following the Blaschko of lines. It is highly resistant to treatments of all types, whether topical, systemic, or laser treatment. We found in literature that the manifestation of ILVEN disease, at least in a proportion cases, may be associated with genetic defect in cholesterol metabolism. And we found one article about the targeted epidermal lipids for the treatment of Mendelian disorders of conification. The Professor Kristy from Freiburg, Germany, and Professor Happel found that they make a topical cream consists of simvastatin, and we try in our patients. This is the girl with ILVEM, inflammatory linear verrucous epidermal nevus, and this is 10 weeks after we do the treatment with vitamin D lotion and simvastatin 2% ointment, and it's better. But we cannot treat the hyperkeratosis nails. For the conclusion, in many patients with genetic syndromes, dermatologic manifestations are helpful in establishing the diagnosis. A good anamnesis and clinical evaluation to diagnose the hidden syndrome associated with extracutaneous involvement is imperative. All health practitioners should recognize the so-called red flag in dermatologies and dermatologic skin disease or genodermatosis, and when to refer the patient to a specialized center. In limited resources settings such as in Indonesia, a diagnosis of hereditary skin diseases often rely on clinical picture. So there are three red flags in I have explained you, and the limited resource setting has opened the way for the introduction of innovative treatment. I thank you very much for the opportunity. Thank you.
Thank you, Prof. Retno Danarti, for the very interesting presentation with cases of genetic skin diseases. And a presentation before the break. There will be Dr. Kristy Iskandar, M.Sc. Ph.D., pediatrician, consultant, neurologic, pediatric. Good morning, Dr. Kristy. Thank you for being with us this morning. And on the screen, we will see the bio sketch of Dr. Kristy. Please. Thirty minutes presentation time is yours, Dr. Kristy.
Could you help me with the slide in the computer? Thank you very much for your kind introduction, Dr. Mira. Good morning, dear professor and students. So I would like to share the precision medicine in Duchenne muscular dystrophy. Yesterday, Professor Wang Choli already briefed you about the precision medicine especially in neurology. I'm a pediatric neurologist and he's my professor. So I think you already get a flavor about the precision medicine in neurology diseases. Where should I point? Here. Sorry for the problem. So my outline is introduction to DMD, how to diagnose the DMD, management of DMD, and precision medicine available for DMD. So I think you already know about Duchenne muscular dystrophy. It is caused by a DMD gene mutation that causes dysfunction of dystrophin protein, causing the progressive muscle weakness and premature death. Its incidence is 1 in every 3,000 to 5,000 boys. So in Indonesia we have 20 million populations. It is estimated 500 boys will be born with DMD every year. So you can imagine the burden in Indonesia. They all will die prematurely. The DMD gene consists of 79 exons. I think I got a problem. Okay, sorry. Yeah, this is the dystrophin. It connects actin into the membrane, and you can see here there are 79 exon. There is actin binding domain, central rod domain, and dystroglycan binding domain, and carboxy terminal domain. Yeah. And there are the types of mutation in DMD are deletions. Most of them are deletions and duplications, and about 30% of them has point mutations. And we can see here that there is a hotspot in the DMD gene, that the hotspot would be at the exon 2 until exon 20 and exon 43 until exon 55. That is the exons which the mutation is common to happen. And maybe I want to remind you about the inframe. Oops. Yeah, sorry. About the in-frame and out-of-frame mutation of the MD gene. And you can see here, we have the 3 codon. So if the mad cat ate the fat rat and the big hat, and the relation is the multiplication of 3, so we can still read the whole sentence. The mad cat ate the big bat. It's not correct, but it's still readable. So this one is Becker muscular dystrophy. But out frame errors is when the mutation is not multiplication of 3. So like the mad cat ate the fat rat and the big bat, and there's only 2 codon deletion, and then we cannot read the sentence at all. We don't understand that at all. It would be manifest as Duchenne muscular dystrophy. So from these sentences, you can understand that Duchenne muscular dystrophy has more severe presentation than Becker muscular dystrophy. And then there are exon skipping methods to correct the DMD to become DMD, so that we can skip the exon and then it will make the reading frame become in frame again. Maybe I can tell you later about these exon skipping methods. So the MD diagnosis is diagnosed by genetic testing. This algorithm is written in 2010 and 2018, and it might be already very common in Western countries, but in Indonesia it's not too common. So if we got a patient with unexplained increase in transaminase, a family history, or symptoms like delay walking, Gower signs, or two walking, we have to check about the creatinine kinase level in the serum. And if it is increased and we suspect this patient has DMD, we have to proceed for DMD gene deletion or duplication. So only single gene testing. You don't have to do exome sequencing or genomic sequencing. You straight do the single gene test for DMD. That is MLPA, multiple ligation probe amplification, which can detect deletion or duplication of exons. Then, as I have told you before, that about 30% of the MD gene mutation is point mutation, so you will not get a positive result on MLPA, then you will, no mutation found, you will proceed to genetic sequencing. We can use Sanger sequencing in this algorithm, but given that there are so many exons of the MD, 79 exons, it will be too tedious and pricey. So using whole exome sequencing will be more efficient in this occasion. Actually, there are 3 types of next generation sequencing: targeted panel, whole exome sequencing, or whole genome sequencing. You can choose between the 3 of them, but I think for cost effectiveness, targeted panel or whole exome sequencing is cost effective. Targeted panel is good and cheap, but not in Indonesia. But I think in other countries, targeted panel is cheaper than whole exome sequencing. But if you have your patient is not, your patient's genes is not included in this panel, you would miss the diagnosis. The whole exome is better because if this is a new presentation, a new diseases, you still can find the diagnosis. And if genetic sequencing also yield negative result, no mutation found, we could do the muscle biopsy, whether the dystrophin protein is present or not. And if it's not present, then the MD is unlikely and consider alternating diagnosis. So in our institution, actually, we still do the muscle biopsy because it is covered by the health insurance. But genetic testing we have to buy by ourselves. However, now there are a new genomic initiative from the government, from the Minister of Health. They give us the reagent for MLPA, so we can now give free genetic testing to the MD patients come to our center. Yeah, this is the multiple ligation probe amplification. It is very easy to read the MLPA. You can see here there are 79 exons. This is there are 2 probes, and it is maybe too small, but it's like 1 to 79. But it's not in order. Okay, so yeah, you can see in the control the amplification is 1. So in if you have one the MD gene in your X chromosome, there will be in this line. But if you have deletions, for instance, this deletion exons 49 to 50, then the mark will be dropped here. So you can just read this is deletion of exon 49 to 50, and you can see that it is very every DMD patient would have different deletion, but this one is a hotspot mutation. And how about duplication? It's also easy. You can read that there are 2 copies and twice. The duplication is on 53 to 60. Okay. Even this is for the patient, right? But even if you are a carrier, you can also read the MLPA. For instance, if the patient is if the patient got deletion in the exons 49 to 50, if your mother is, if the mother of the patient is carrier, then this dot should be in half, because the mother has 2x. If she is a carrier, she will have a half dot. And when the mother is carrier for the duplications child, then it will present as 1.5. Yeah, it's actually a simple mathematics, because mother or sister have 2x, but the patient have only 1x. Yeah. So MLPA is actually a simple method. It's only required a PCR machine and fragment analysis or Sanger sequencing machine. So it is actually can be done everywhere, but in Indonesia, it's only 2 centers that can do the MLPA testing. The first one is Eijkman. So Eijkman in Jakarta, in Universitas Indonesia, but nowadays they moved the center into a new institution, and they don't serve for the MLPA study anymore. So right now we are the only center receiving samples for the MD gene testing by using MLPA studies. And because the government helped us, so now we can serve the free testing for MLPA for the MD. And when the MLPA testing is negative, we proceed to next generation sequencing. It is a cost-effective and fast methods to know to sequence all of the exons in the genome. We didn't do the whole exome sequencing in our institution. We sent to abroad. We tried to do it in our center. We have the machine, but the cost is very, very pricey. It's about maybe 10 times more expensive than we send them to abroad. But I hope that in the future we can do in our center, because we have the machine, we can do the laboratory study. We have difficulties in bioinformatics, but I think for neuromuscular disorder it would be easier. And this is the muscle biopsy as a diagnostic tool. It is also very good, but it is invasive. And not all Indonesian center has the dystrophin dye. So actually only in UGM we have a dystrophin dye. So other centers usually will just directly proceed to genetic testing by blood examination. So let's move to the precision genetic medicines for the MD. So before we go to precision medicine, there is multidisciplinary care and steroid as the core of treatment for the MD. There we need a lot of management, from rehabilitation, orthopedic, psychosocial, cardiac, pulmonary, gastrointestinal, and corticosteroid management after the diagnosis has been established. Yeah, and the development of precision genetic medicine for the MD may be the first in the world. It has begun since 1978, and the oligonucleotide, antisense oligonucleotide has been discovered in 93. So the MD precision medicine is one of the pioneer of precision medicine in the world. And so we have 3 types of precision medicine. The first one is exon skipping. The goal of exon skipping is to alter pre-mRNA splicing in order to restore the reading frame, like I already present to you before. And this restored of reading frame will allow for production of an internally shortened dystrophin protein, which is functional. This exon skipping is made by RNA, so RNA-based therapy. You can see here that if a patient has deletion in the exons 45 to 54, it will make a stop out frame dystrophin transcript, and it will ruin the codon, and the dystrophin will be truncated or dysfunction. Then if we have an antisense oligonucleotide attached to the exon 44, then the exon 44 will be skipped, and the 43 can be attached to the 55 and make a new in-frame dystrophin transcript missing exons 44, 54, so it become in-frame deletion. But you can imagine that the dystrophin can be produced again in the shorter type and causing the BMD-like phenotype. Okay, I like the picture written by Professor Matsuo in a caricature of what is this train. So you see in the DMD patient there is deletion of one piece of puzzle here, and it caused that the train is stopped, ruptured. So and the treatment by exon skipping is that by you kick out the next puzzle piece, and it can make a whole new shorter train, and its function as like BMD. So this is the status of the most advanced target therapy for motor neuron diseases and muscular dystrophies. You can see here that SMA has already until the phase 4 for gene replacement therapy and also antisense oligonucleotide. This is the paper last year. But for the MD, it's now the antisense oligonucleotide also has been marketed internationally. And the gene therapy actually this year is already in the phase 4 because the FDA just approved that gene therapy for the MD. So, okay, this is the current pharmacological strategies for treating the MD. We do the dystrophin restoration by exon skipping, stop codon read-through, and gene therapy. And anti-inflammatory, we use the corticosteroids as the core of the treatment. Yeah. I will show you one by one about the MD precision medicine, which has been approved. FDA approved is exon skipping, targeting exon 45, exon 55, and exon 53. And then the stop codon read-through is EMA approved. It is called the ataluren. And the gene replacement therapy just a few months ago approved by the FDA. Yeah, this is the papers. And it is said that by using this exon skipping strategy, about 80% of the MD patients amenable to exon skipping. But as you already know that exon skipping is really specific, so only a percentage of the MD patient can receive the treatment because it is very specific. Yeah, this is so you have to have the mutation that is amenable to exon 51, exon 53, exon 45, 44, 50, 52, or 55. Other exon skipping is under clinical trial. And how to know that whether our patient is a candidate for exon skipping strategy, we can use these tools. These tools is available at the Parents Project of Muscular Dystrophy from US. and you just can enter your exon deletion, like for instance 45 to 50, and then submit, and then they will tell you that you are amenable to exon 51 skipping. And if you are, for instance, 45 to 52, you are amenable to exon 53 skipping. Yeah, and the study showed that deletion associated with exon 44 skipping result in higher dystrophin expression and milder disease phenotype. They also showed that there is significant delays in markers of disease progression compared to patients with no residual dystrophin. Okay, so this is the picture of our patients. So yeah, as you know, DMD is a genetic disease, so it's not uncommon to have one family has more than 2 siblings with DMD. For instance, this mother, he has 4 boys, and 3 of them have DMD. And this is the patient from Belgium. He already got the exon skipping 51, and he has the same age with my patient. He was about 22 years old that time, and he is maybe the oldest patient to climb the Borobudur temple. Have you ever been to Borobudur temple? Not yet? You should. It's not far from here, and it is the biggest temple, Buddhist temple in Indonesia. It is very high and steep, and it is very hot, but he can manage to climb by himself. And you can see this is the natural history of the MD. At 20, you will be in the wheelchair, and you cannot even lift your hand. You only can use your fingers, but not lifting your hands, your arms. Okay. And unfortunately, this patient is he already graduated from UGM. He is the student of University Gadjah Mada University. Both the big brother and the younger brother, and they are already passed away when they were 23 years old. So this is a very big gap between the Western countries and Indonesia. The other treatment is to correct the nonsense mutations using what we call the read-through. So the point mutation has to cause the stop codon mutation, and then this read-through mechanism can read the stop codon and restore the mutation. This is European Medicine Agency approved, and it is already internationally used, and it can help the ambulatory stay to become longer in the patient with DMD. The last one is the gene therapy for DMD. It is the gene therapy, so you include the mini or micro dystrophin gene into the adenovirus factors. It's the same principle with the SMA, adenoviral factors, and I think many more gene therapies is come and in the clinical trial. And because the dystrophin is very big, it's 79 exons, so they use the microdystrophin to for this DMD disease. Yeah, this mini or this is microdystrophin is actually looks like the dystrophin in the mild DMD patients. It actually has to be this big, but the adenovirus cannot lift them, so they make the microdystrophin. This gene therapy has just approved on July, I think on July this year. So you know that gene therapy is developing very fast. I think every month they are having a new drugs for rare diseases. And this is the child who got the gene therapy, and he still very good, and he showed no difficulties in motor function. But however, you see the price is $3.2 million. If you all the molecular therapy is very expensive. For instance, for exon skipping drugs, the cost is $750,000. I have to cheat because I cannot remember so many zero. So if you imagine Indonesian salary on average is $7,000 a year, and this drug is 750,000. So it's more than 100 times of Indonesian salary on average. So it's very, very, very expensive. I think we could not afford to have that kind of drugs in Indonesia, but we hope that we can join the clinical trial to get the drug. And one of the pharmaceutical company, the Sarepta, they want to start the clinical trial in here for exon skipping 51, and we hope that our patient can join the clinical trial. And I really admire Professor Damayanti because she can get the drugs to her rare disease patient and help the patients. This is the assessment of systemic delivery of gene therapy, and we can see here from the North Star ambulatory score, which measure the motoric score, is getting better with the microdystrophin. And this is gene-specific therapies for the MD thesis in clinical trials. There are so many of them, and it's still ongoing from Japan and also from the US. This one of them, the Sarepta, will propose us and also the Minister of Health to be used in Indonesia for clinical trial. We hope that next year we can start the clinical trial for exon skipping 51. So how about our patients' eligibility to precision medicine? And we can, at first we can see here that Indonesian DMD patient survival rate is low. As you can see that the sample of our patients who has passed away, we can see here that the age of death is around 17 until 25 years old. It is the same with what happened in Japan, like here, about 25 years old, and it was in the 1984. So it's like 40 years different between Japan and Indonesia. And we collect the samples. We do the genetic testing for the MD patients since 2017, and we got 127 pediatric patients referred with the MD. We do the clinical history, physical examination, CK, EMG, biopsy, and MRI and ECG is done. Not all patients got MRI. It depends on the complaint. We do the single gene testing for the MD at 85 patients, and as you can see here, although they are referred as a DMD, actually they have an SMA phenotype. So we also do the PCR referral for SMA for 7 patients. We have 35 patients still lack the molecular diagnosis, like the MLPA and SMA test is negative, and then we do the whole exome sequencing. We found another DMD patient has a point mutation. We also find varieties of limb girdle muscular dystrophy group, including one myotonic dystrophy. The Becker myotonic dystrophy.
Excuse us,
Yeah.
Dr. Kristy, the time is up, so
Oh,
you can proceed to your
Thank you. Okay. So this is my last slide. Yeah. So the patient population available for exon skipping trials, we have that patients exon 51 and exon 45, 52, 53, and also 7 patients amenable of retro therapy ataluren. Okay, this is the conclusion. Genetic test is used for DMD diagnosis. Precision medicine is available, but there are inequity of the drugs in the world. Thank you very much for your kind attention.
Thank you, Dr. Kristy, for a very interesting presentation. And we will have a short break after this for 10 minutes. So please come back in 10 minutes in this room to continue the next 2 talks. Thank you.
Okay, everyone. So sorry for interrupt your coffee break session. So I would like to invite all the participants and also honorable speakers and moderators to join with me inside the auditorium for the next sessions. Once again, I would like to invite all the participants and honorable speakers to join with us inside of the auditorium to start the next session. Thank you. Okay, everyone. So once again, I would like to invite all the participants and honorable speakers and invited guests to join with us inside of the auditorium to start for the next sessions. For the next session, we will have two speakers. One speaker from Singapore and one speaker from Malaysia. And once again, I would like to invite all the participants to join with us inside of the auditorium for the next session.
Dear participants, welcome back to this panel. There will be two talks in this session. We will proceed to the next talk. from Shih, Ph.D. from Precision Health Research, Singapore. He will be present online through Zoom. Good afternoon, good morning, still here. Good morning, Shih.
Good morning. Can you hear me well?
Yeah, very clearly. Thank you for your presence with us this morning. We will show the short CV, the bio sketch of Shih, PhD shortly. Please. I would like to invite our distinguished speaker, Shih, PhD, to give the talk for 30 minutes. Time is yours.
Thank you very much. I'd like to first thank Prof. Gunadi and also the organizing committee for giving me the opportunity to share Singapore's experiences. I would also like to send my apologies for not being able to be present in person. I had a big budget meeting yesterday to discuss the next phase of my program, and unfortunately all the flights were not in my favor, so I cannot be there in person. So I'll share my slides now. Can you see my slides well?
A minute. Yeah, it's clear now. Please, Prof.
Thank you very much. So I will give an overview of the National Precision Medicine Program, which is overseen by my organization called PRECISE. So we are implementing phase 2 of the National Precision Medicine Program. I will first give an introduction of Singapore. I understand there are some international colleagues and students in the audience. Thereafter, I will introduce and elaborate on the National Precision Medicine Program, all our goals, and also various elaborations along the way. So Singapore is a small sunny island city-state at the tip of the Malay Peninsula. We are only 31 miles across, and also just 17 miles north to south. So if you're a marathon runner, no problem, you can run across Singapore within a day. We are 1 degree off the equator, so we are island country, city-state with tropical weather, sunny practically all year round. We rank highly in the various global indices. We have good healthcare, good quality of life. We have one of the lowest infant mortality rates in the world. And also we are one of the longest living human beings on the planet. Singapore was also the place where the sort of 2018 North Korea and United States Singapore Summit was held. It is also the basis on which the novel and the movie Crazy Rich Asians was produced. And we are also home to the first F1 Formula night racing. We hosted our 15th installation in September, just a few months ago. I share sunny island Singapore with 5.64 million other residents, which is only half, as I understand, of the Jakarta population, so we're really quite small. And of the 5.64 million residents, 3.55 million are Singaporean citizens like myself. The rest are transient workers or permanent residents who have a long-term past in Singapore. Singapore's ethnic mix of the citizen population, we have 3 major ethnic groups, and that composition has been very stable for the last 10 years. There is majority Chinese, then there is the Malay ethnic group, and then there is the Indian ethnic group. There are others, they are usually Eurasians, so of mixed parentage. Singapore's population, like the most part of the world and also in Asia, we are rapidly aging. Close to 20%, 18.4% of our population are aged 65 and above. Singapore's economy is, there are two major sort of industries supporting the Singapore economy, the pharmaceutical and also the medtech industry. So for pharmaceuticals, we manufacture 6 of the top 10 drugs by global revenue. And with regards to medtech, we are home to more than 60 MNC medtech companies, which has called Singapore their HQ. The success of these two industries is not by chance. It is partly due to the government's sort of deliberate effort to make sure that there is sustained and continued investment in research, innovation, and enterprise, so as to build knowledge-based economy. And annually, the government invests about 1% of the national GDP to support research, innovation, and enterprise. And this is a simple schematic to show that the sort of idea of investing in research innovation started way back in 1995, and our research funding goes in about 5-year cycles. So the plans are rehashed and revisited every 5 years. So now we are in our 7th installation. And the government has pledged 25 billion to support this current tranche, which runs from 2021 to 2025. So precision medicine was identified as one of the key domains or topics that can actually continue to help to support and drive Singapore's research, innovation, and enterprise strategy. And it is for this reason that the government funded the National Precision Medicine Program. It is a 3-phased program. So we started small and we scale accordingly with each phase so as to learn from the mistakes and build upon our successes. We started in 2017 where we've recruited and sequenced 10,000 Singaporeans. At that time, it was a big number to us, never done before. So we use that as a proof of concept that we can actually pull the research community together to do things together and to sequence 10,000 and deliver successfully the sequences of 10,000 Singaporeans. So we are currently in the middle of phase 2 and also in the middle of the entire sort of 10-year to 13-year journey of our National Precision Medicine Program. At the end of the Precision Medicine Program, we hope to have sequenced up to 1 million Singaporeans. I would like to mention that this is a whole of government and whole of Singapore effort, so that we can get the stakeholders to buy in and to work with us along the way. We do our part to make sure no agency or institution is left out of the National Precision Medicine Program. So along the way, as we finished phase 1, as I mentioned that the primary impetus at the start was to support Singapore's RIE goals. But then along the way, we collected sort of other goals. As mentioned, Singapore, like many other countries, are facing severe pressures on the healthcare system. We have an aging population, rising chronic disease burden, and also not to mention rising healthcare costs. If these are not sort of managed properly, then we expect that most of the government spending will have to go to support healthcare costs, which is not desired because then other sectors have to be compromised in terms of funding. So the Ministry of Health is also very interested in the precision medicine program that we have developed because of the potential of early detection, screening, and also early disease treatment and intervention. Another reason why we wanted to embark on the National Precision Medicine Program is also because of the Asian disease phenotype. We know very well that certain diseases are more prevalent in the Asian population than the Caucasian population, or they may present differently. So take, for example, type 2 diabetes. In Asia or South Asia, we have this phenomenon called the skinny diabetics. So the patient may be well within the stipulated BMI, but they actually develop type 2 diabetes. This is very different from the Western Caucasian population, where type 2 diabetes is typically associated with a high BMI. We also have the version of lung cancer, where it's this version of the mutant is only prevalent in the Asian population. I believe gastric cancer is also more common in Asia than in Western population. So taken together, we would like to use the National Precision Medicine Program to address these various gaps in terms of our understanding of the Asian disease while supporting the national agenda. So phase 1 started in 2017. It has concluded in July 2021, where we successfully sequenced over 10,000 Singaporeans. The 10,000 Singaporeans were pulled from 6 existing research cohorts. So we had newborns, the age group from 0 all the way to 84 years old. And we had at that time, because it was the proof of concept pilot project, we only collected about 20 phenotypes. Despite the modest effort, we were able to also help to push some things in terms of regulations. We are very pleased with that. So we work closely with the Ministry of Health. They recognized that, they needed to put in a code of practice on how to provide clinical genetic testing. Otherwise, all the doctors will start to order and they may lead to sort of irresponsible overconsumption. So the Ministry of Health came up with a code of practice. And also this was something that we're very proud of. Together with the Ministry of Health, they heard and noted that precision medicine is, the next wave of medicine, and genetic testing could be very widespread. And so they put in a life insurance moratorium to ban the use of research genomic information for insurance underwriting. Another aspect that we are quite happy with, is quite satisfied with, is the interest from the industry. So even at 10,000, there was sort of significant interest from industry to want to collaborate and to partner the National Precision Medicine Program. I want to elaborate a little bit on the data that we found from the first phase, 10,000. So this is a UMAP plot. It's just a way for us to sort of juxtapose the different genomes that were available at that time. So if you look at this red and yellow plot here, the red signifies the Singaporean Chinese population's genomes. And if it maps nicely to that of the East Asian genomes. On the bottom here, bottom right, which is the purple and pink dots, the purple dots are represented by, the purple dots represent the Singapore Indian ethnic group's genome, and it maps nicely to that of the South Asians. So which is South India, right? And this one here is China, southern part of China. And the reason why it maps to these two populations in terms of genome is not surprising to us, because our forefathers came from the southern parts of China and also southern parts of India. What was surprising to us was that the Singapore Malay ethnic group did not map to any of the genomes that were publicly available at that time. So this presents an opportunities. It also underscores the point that Asian genomics is very understudied and undercharacterized. From this 10,000, we also identified more than 100 million, close to 180 million variants. And of these, up to 43% are actually unique, are not publicly available or present in these two databases. So again, it shows that because probably the Asian genome is understudied, and that's why a lot of the things that we find are actually novel. And even in our small population of small sample size of 10,000, we were able to find distinct ethnic differences in terms of the disease predisposition and propensity. Take, for example, this bar, which says, which is tagged to BRCA1, 2. So we find that in the Malay ethnic group, they actually have a higher frequency of BRCA1, 2 mutations. And this means they are more likely, maybe more likely to develop breast cancer and ovarian cancer. In the Chinese ethnic group, as you can see here, the LDLR allele, the frequency is a lot higher in the Chinese population. And this means that the Chinese have a higher predisposition to developing familial hypercholesterolemia. And as you know, familial hypercholesterolemia, patients accumulate cholesterol very rapidly. And and suffer a severe cardiac event in their early 40s or 50s, which is way above or way earlier than the standard average population, who may more likely to suffer the heart attack in their 60s and 70s. We found that 1 in 140 Singaporeans actually harbor or have this FH, likely to harbor FH. And in the Indian ethnic group, we find that they are more likely to develop hypertrophic cardiomyopathy. So even with just 10,000, we were able to find these differences and unique sort of insights which were not reported before. And as I understand, this 10,000 ethnic genome still is one of the largest Asian genome in the public databases. So all this data is actually available. The phase 1 data is actually available for research use. We have developed web services to support researchers and clinicians who wants to query the data set. So you can submit your data request, fill in an application form. It's reviewed by a data access committee. If your IRB is aligned and also your general research goals are aligned to the National Precision Medicine Program, and you come from a credible institution and agency, it will most likely be approved. To date, we have approved over 80 applications for data use. The data of the Sp.KK phase 1 is actually also being used as a Singapore reference genome, and is used by the doctors and also the scientists to diagnose diseases. So now we are in phase 2, where we want to power Asian precision medicine. In phase 2, we look to recruit and enroll 100,000 Singaporeans. So these are some of the various articles that were reported in the newspaper to generate awareness and also to create buzz and hopefully to refer more people to our program to participate. This year is our Minister for Health. As mentioned, Ministry of Health is very supportive. And so Minister for Health, being very supportive as well of the program, also participated and donated his samples to our phase 2 of the National Precision Medicine Program. So phase 2, the way we are collecting the samples is a combination of retrospective cohorts. About 50% is retrospective cohorts and 50% are prospective cohorts. So of the 50%, the active efforts to go onto the ground to the various community centers and associations to gather interest and also volunteers. They range from 21 to 84 years old. And for this cohort, for phase 2, we are a bit more deliberate in terms of our recruitment because it's intended to be a population cohort study. So we try to mirror as closely to the Singapore population as possible. So for example, in terms of the prevalence of diabetes, it shouldn't vary too far. And likewise for hypertension and also high cholesterol conditions. Yep. We are currently at 81,000. So we are very likely to hit the target and complete recruitment by 2024. Sequencing is also progressing very well. After initially some hiccups, for about 3 to 4 months, the teams overcame those hurdles, and now sequencing is on track. Every week, they are able to churn out sort of fixed numbers of sequences, and now we have sequenced over, I believe now, by this week, over 45,000 genome sequences already. And by end of next year, we should be able to sequence all 100,000. This effort to sequence 45,000 took us maybe 1.5 to 2 years. I want to mention that in phase 1, it took us about 3 years to sequence the 10,000. So this is a demonstration that, we built upon our knowledge accumulated in phase 1, and then we expand on it. So in phase 2, also we are including many more parameters in our phenotype characterization. So these are some of the categories of data points and phenotypes that we're collecting. I will elaborate over the next few slides. In terms of questionnaires, we are collecting health and lifestyle information, socio-demographics, what is their medical history, alcohol consumption, various quality of life. So these are sort of standard questionnaires. And also there is a section on cognitive tests, and this is based on the UK Biobank tool, so that we can allow data interoperability. Likewise, there is a very extensive dietary and food frequency, dietary habit collection. I went through the battery of, I participated as a participant, and the whole battery of tests and clinical evaluations takes about 4 to 5 hours. And physical measurements, height, weight, blood pressure, ECG, there is some heart, and there is a sort of treadmill, arterial stiffness. They use a carotid a scan, spirometry, hand grip strength as well. And at the end of the 4 to 5 hour on-site clinical assessment, we are issued an activity tracker for 7 days. After 7 days, we mail the tracker back to the team for their analysis and evaluation. Then there is also comprehensive imaging. There is carotid ultrasound. There is also eye imaging, and then the DEXA scan to ascertain bone density. We are also asking, as you saw earlier, socio-demographic factors and sort of data to understand, how does the environmental exposures in affect the Singaporean health. So, we know that environment exposures to pollutants can affect your behavior and also your health. And so we want to understand beyond the standards of physical measurements, what are other factors, including environmental exposures and environmental factors that affect Singaporeans' health and disease balance. So all this is asked within that 4 to 5 hour clinical assessment. So at the end of the program, if we can deliver this successfully, the Singapore SG100K study would exceed and be certainly comparable to other global programs such as the UK Biobank, all of us, and also the study in Germany. There are 3 key pillars to Singapore's National Precision Medicine Program. I mentioned just now there was research, innovation, and enterprise. With regards to innovation, we are looking at healthcare innovation. So in phase 1, my colleagues mapped out the pathway, a patient journey, if you may, from trying to get, or a physician's journey to try to practice precision medicine approaches, such as ordering a genetic test. So they mapped out, there were like 13 steps along the way. And each of these steps are actually full of barriers and challenges to overcome, right? For example, from choosing the right test, not all doctors know or are adequately trained in that. So they may not be able to order or understand enough to order the right test. There is also the pre-test counseling. We do not have enough genetic counselors in the ecosystem. Somebody needs to take the patient's consent and document their choices, but is the physician or the attending nurse adequately trained to explain their risks and advise the patient on this and document their choices? Sequencing, collecting the samples, and then sequencing data. How do we even transfer the sequencing data back to the physician? The current IT systems or healthcare IT systems are not set up for sequencing data. So there are a lot of all these things that are along the way. And then obviously, when you return the results to the clinician, the physician, does he know enough to be able to explain the results to the patient? Again, there's a lack of training, and also there is not enough genetic counselors. If we want to scale up and fully deploy clinical precision medicine approaches in the Singapore's healthcare setting. So instead of trying to, we know that the healthcare system in general is a very inert and very big ecosystem of many stakeholders. So they are generally inert to innovation and slow to change. So instead of trying to, go in and go big and try to intervene and make many changes, we funded instead 5 small clinical implementation pilots so that we can collect sufficient data. We don't try to attempt and change the healthcare system at one go because that will just upset too many people. So we had an open grant call and, for physicians to submit their proposals. If they think that they want to, they have seen perhaps, or they think that certain precision medicine approaches can change the clinical workflow or positively impact the patients, they were welcome to submit the research proposal. So this is still, even though it is to be used in the clinical setting or collecting sort of clinical data, this is generally still in the research space. So we received, I think, 13 proposals, of which we finally awarded 5 proposals. And these are sort of diseases that are relevant to the Singapore population. For example, for familial hypercholesterolemia, early breast cancer screening. Then I mentioned just now BRCA1-2 mutations, which is related to hereditary and familial cancers. Then there is also one on primary glomerular diseases and also one on pharmacogenomics. So all these 5 projects are led by a clinical lead as well as a health economist lead. So apart from trying to gather clinical information, for example, of how putting genetic testing further upfront in the clinical workflow, how much cost savings will it bring to the healthcare system? How does it affect or positively impact the patient outcome? All these are being collected. So other than clinical outcomes, as mentioned, there is also a key component, which is the health economics component, because there is a lot of concern, not just with the Singapore government, but I think generally as well with various governments, that precision medicine is going to cost a lot of money. So with the health economics aspect in there, we can come up with empirical data, right, to inform that perhaps, yes, it may cost a lot of money in the beginning when you have to set up infra, but in the long term, you actually save a lot more. Or if even if it's not sort of monetary savings, you actually gain a lot more in terms of the socioeconomic benefits. For example, if you do breast cancer screening early, you pick up breast cancer earlier. So the woman doesn't have to receive very aggressive treatment, right? And so therein you save some money. And also if the woman doesn't receive very aggressive treatment, maybe she recovers better and she can go back to the productive workforce and contribute to the economy again. So therein lies the importance of the health economics aspect of these 5 clinical implementation pilots. They're all progressing well. As with all clinical studies, there are usually hiccups with the IRBs trying to get the hospitals to work together and trying to get various cross-institution agreements and contracts in place. But they are generally progressing well now. So they have collected, they're recruiting patients themselves, and they're also recruiting for some of these studies, their relatives for proband and cascade screening tests. There is a lot of interest in Singapore's precision medicine program, primarily because of the Asian diversity and also the deep phenotypes. If successfully delivered, the SG100K will be one of the world's most deeply characterized Asian cohort. And also it's a longitudinal study. And the fact that there is a whole of government, whole of Singapore involvement in this demonstrates our commitment. So there is a lot of interest in the Singapore National Precision Medicine Program. So we want to capitalize on this interest. So this is my 3rd pillar. So there is, I mentioned research just now, which is to create 100,000 database or a cohort of 100,000 Singaporeans. I mentioned about healthcare innovation. Now I'm going into the 3rd pillar, which is the enterprise pillar. Most of Singapore's research projects come with this enterprise angle. We have to, at the end of our report card, our funding report card, demonstrate that we have actively engaged and attracted co-investments from industries, companies, big and small. Better still, if they come to Singapore and they set up because of the research environment and the research project. We need to demonstrate how much research dollars we have managed to attract to complement the public funding for the research project. So again, as mentioned, there is a lot of interest in the precision medicine program. In phase 1, there was modest interest. We collected about $11 million of cash and in-kind. Now going into phase 2, we have a more sort of deliberate and approach to capitalize on this interest. So we have a 3-stage. First, I will elaborate them over the next few slides. First, we want to build strong public-private partnerships. Then we want to attract pharma companies to co-invest in us. And taken in all of these resources that are put in, the data sets, perhaps the funding that comes in, we can then return it to the local ecosystem and power the local ecosystem. So in stage 1, we actually formed a joint partnership with Illumina to create the largest population genomic database in Southeast Asia. This information is a bit outdated. I think we're at over 45,000 now, and at sequence at 41 times coverage. Obviously, the partnership with Illumina or other tech companies allows us to achieve and deliver gold standard data sets and good quality data sets, which can then be used to attract pharma companies to co-invest into the National Precision Medicine Program. And therein, with their co-investments, we can amplify the data sets and the quality of the data sets. So we all know that clinically validated drug targets are 2 times more likely to lead to approved drugs. And that's why a lot of pharma companies are very interested in such national precision medicine programs. We have seen the success of the UK Biobank, which were able to attract industry funding, repeated rounds of industry funding, and likewise for FinGen.
Excuse
Can you hear
us, Dr. Hui.
Yeah.
Time is almost up.
Okay.
Thank you.
This is my last 3-4 slides. So we also seen the success of FinGen, and we want to emulate this model of using the core data set to attract repeated rounds of industry funding. So we commenced our efforts in 2019, engaged many companies, and then we met them in person, and now we are on the way to negotiate a Masters of Research Collaboration Agreement, and we hope to sign this by the middle of next year. I'll give you some examples of how stages 1 and 2 has gone on to power and support stage 3. So with the signing of the partnership agreement with Illumina, Illumina is not a sequencing service company, so they outsource the sequencing to a local Singaporean sequencing service provider, Novogene AIT, which some of you in Indonesia may be familiar with. And because of the guaranteed base load of 100,000 samples from Singapore's National Precision Medicine Program, Novogene AIT was immediately able to increase their revenue. With the increased revenue, scale and expand operations in Singapore, creating good jobs for Singaporeans. And then they were also able to expand beyond Singapore to regional countries and perhaps beyond. Another example of how we have powered the local ecosystem. So 3 of the 5 clinical implementation pilot projects required clinical grade sequencing. There was no such sort of thorough end-to-end sequencing, clinical sequencing provider. So we called for a tender, and LifeStrand bidded for the project. Again, they are guaranteed this base load from the 3 CIPs. And although LifeStrand didn't have the end-to-end capabilities, they partnered Ambry Genetics in the US, and it's in the process of tech transfer. So because of the CIP business opportunity, LifeStrand is able to scale up and increase their capability and capacity with tech transfer from Ambry Genetics. My last example is this. I mentioned just now that a lot of the findings from the Sp.KK were unique. And if we actually used and try to sort of assay them using sort of standard commercial panels developed for European populations, 24% of the Singaporean population would be missed out and be ascertained as healthy, when actually they are not. So using this information and the data set, the team is now developing an Asian screening panel for use in the Asian population, to service the Asian population, to support early detection as well as disease prevention. So my last few slides are about building and maintaining trust. Depending on the time, I can skip through this. But, there's no way we can sequence 100,000 and want to move on to 1 million without building and maintaining public trust. So we have done multiple public engagement efforts, over 1,000 Singaporeans, and learn what are their concerns about us sharing data with industries. So in general, Singaporeans have a high trust in the Singapore government, in particular the Ministry of Health, to sort of be custodians of the data set. They have very low trust in insurance companies, with overseas universities and IT companies. I think during that time, when the survey was done, it was when I think it was reported that Facebook and perhaps a few other companies were, in inverted commas, sharing data, personal data or data with third parties. But in general, there is good support from Singaporeans for sharing data with companies to enrich and understand better how to improve Singaporeans' health and also to create better drugs for Asians. But Singaporeans want to make sure that there is accountability and there is fairness. There is also, when we share the data, it has to be done in public interest so that there is return of benefits to the society, not just to the participant or the volunteer, but to Singapore in general. And there should also be transparency, who is accessing the data and for what reasons. So that is my last slide. And this is at a glance, what are the phase 2 achievements coming up from MPM phase 2. Thank you very much.
Thank you very much, Dr. Wei, for the very insightful presentation. The last but not at least, I will invite Assistant Professor Teguh Haryo Sasongko, MD, Ph.D. from International Medical University, Malaysia. On the screen is the bio sketch of Prof. Teguh Haryo Sasongko. Please, time is yours.
Thank you, Madam Chairman. I have an insider information from the organizer. It's something after my presentation, your lunch. Yeah. Thank you. All right. So I'd like to present something which might be different from what the other presenters have presented before. I'd like to present something on evidence synthesis in terms of how we can apply precision medicine in rare disease. It's because what is important in precision medicine for rare disease, that will be the genetic diagnosis and also the selecting the appropriate drugs or appropriate medications for them. That requires evidence synthesis because before we can apply them. Okay. So first, before we go there, I'd like to take your attention to this one. What is actually rare disease? The world does not seem to have a common idea about what is rare disease because from one country to another, they have different idea of what rare disease is. When it comes to frequency, rare disease is about frequency, of course. Then we talk about the frequency, about numbers. That range from 5 in 100,000 in Korea to about 80 to 100,000 in the US. But overall, we have about 6,000 plus rare disease in the world. Even though we have this many of rare disease, 84.5% actually fall in the extremely rare prevalence, this one. Yeah, the bulk majority of it fall in extremely rare. Extremely rare meaning it has less than one patient in 1 million live births. So it's extremely rare. And only about 149 rare disease, 4.2%, yeah, of all the rare disease here, that accounts for most of the patients, about 77 to 80%. Right. Yeah, here it is. So, and then most of rare diseases are actually, they actually fall into the category of a simple Mendelian inheritance pattern. Yeah, either autosomal dominant or autosomal recessive, 59% of them. The rest of them are inherited in a more complex manner. Yeah. And 20% of them we have not known yet how they are being inherited. And overall, worldwide, we have about 300 million people suffering from rare disease. So this is a lot of people. This is more than the total of Indonesian population, actually. 72% of the rare disease are genetic and mostly started in childhood. And rare disease accounts for incidence of actually 1 in 15 births worldwide. And this is 100 times more prevalent than childhood cancer. So what we see as rare here is actually not very rare if we see them as a whole. Okay, how about Malaysian figure? I took this quite many years ago, but I think this is still very relevant. There are 56 out of 1,000 babies in Malaysia were born in birth defects. And then each year, there are about 20,000 Malaysian babies born with birth defects. This is by Prof. Tong. Prof. Tong is one of the pioneers of genetics, clinical genetics in Malaysia. And then in an extrapolated data, a little bit less than 10% of the Malaysian population, about 2.1 million Malaysians, actually live with rare disease. This may be underestimated, right? But let's look at the data that are published until now. Yeah, this is a publication 2020, which is relatively recent. And first, I'd like you. This is telling you the number of registered patients, the red bar, for each of different rare disease. And the green bar tells you how many number of patients are receiving treatment for that particular rare disease. Yeah. One thing that we can see here is that the number here is very much smaller than the estimation that we have, but how many patients might have suffered from a rare disease. And second is that the first graph, the first bar here, actually is about congenital syndromes. This is a very broad term. This can be anything under the sun. So this being put as congenital syndromes mostly is because diagnosis cannot be made, because the doctor is unable to really pinpoint a certain diagnosis for these patients. And as the effect is that not that many patients actually are able to receive treatment, because then the diagnosis is not yet established. So this is a problem then. Okay. Now I'll move on to what is the relevance of precision medicine in rare genetic disease. First is that it is very important for genetic diagnosis to be done before we can apply precision medicine. We need to establish properly the diagnosis. And one prevailing method for diagnosis, for diagnostic methodology for rare disease is a genetic methodology. Now, we have the advent of whole genome sequencing. We have the advent of whole exome sequencing. But not necessarily that means that it becomes easier to identify the genetic cause of it. Because when we do, for example, whole exome sequencing or whole genome sequencing of a particular patient suffering from an undefined yet congenital anomalies, not necessarily that you will find, I've had that experience myself, you will find thousands of genetic genetic anomalies, yeah, single nucleotide polymorphisms, mutations, nonsense mutations, copy number alterations, and so on. But it's very difficult. It becomes very difficult for you then to justify which one is actually related to the disease, right? So this is where it becomes very important for each population, each country to actually have their own database reference for their genomes itself. Yeah? And then second is that genetic diagnosis range from simple and low-cost PCR-based techniques until a complex and expensive genomic sequencing. Okay. And then once genetic diagnosis is established, decision for treatment can be made. Yeah? So for doctors, all of you are going to be doctors one day, and now I'm sure now you already sense it. One of the most difficult problems for you to face in your practice will be to establish diagnosis, not to tailor treatment. Treatment will follow diagnosis, but once diagnosis is there, yeah, the treatment will be a lot easier to decide. Okay. I'll give some scenario here. This is given by a speaker yesterday about the case of spinal muscular atrophy. In spinal muscular atrophy, 95% of the patients show deletion of SMN1 gene. And this deletion of SMN1 gene is easily detectable using a simple PCR-based technique. So therefore, with that simple PCR-based technique, then we can see whether this is SMA patient that harbor deletion in SMN1 gene. Yeah? The thing is that when you pick up the deletion, diagnosis is established. But if you don't pick up the deletion, does not mean this is not SMA. It's just, it may still be SMA, spinal muscular atrophy, but it's non-deletion type. Or we also call it non-5q SMA. Okay. So those with losing out or deleted SMN1, that's what we call 5q SMA. So people with 5q SMA now have a treatment, a gene therapy treatment, which is called Zolgensma. But this is particular for patients with 5q SMA, so that you have to be able to know first whether this is 5q SMA or non-5q SMA before you can decide whether Zolgensma is appropriate treatment for these patients or not. This patient is not without problem. This treatment is not without problem. This is now probably one of the most expensive drug in the world. which costs a patient millions of US dollar, yeah, for one injection. Okay. And then next is about tuberous sclerosis complex. In tuberous sclerosis complex, Prof. Retno have mentioned earlier about that. We devised some techniques whereby we can identify genetic mutations in two of the genes that might have caused tuberous sclerosis complex. Tuberous sclerosis complex is a what we know as neurocutaneous disorders. Yeah. And then if we already have information that this is a patient of tuberous sclerosis complex harboring mutations in these two genes, then the treatment will be quite straightforward, because everolimus for patients with tuberous sclerosis complex can do a lot of things, right? 50%, yeah? Overall, oral everolimus reduces the size of SIGA is a brain tumor, astrocytoma, and then there is also neoplasm in the kidney. The size of these two in patients with tuberous sclerosis complex with oral everolimus can reduce by 50%. Frequency of seizure can also be reduced by 25 to 50%, and then that also implements beneficial effects on skin lesions, with no difference in the total number of adverse events as compared to placebo. Yeah. We already know this, so but the message here is that diagnosis is very important before we can move into treatment. But again, both of them, the diagnosis methodology and the treatment modality, require evidence synthesis. The question is that, is it the right diagnostic method? And second is that, is it the right drug? Is it the most suitable treatment in terms of the efficacy and safety for the patients? So the activity of evidence synthesis is very important there. So how about the evidence synthesis for rare disease worldwide? And I'll move on to what happened in Southeast Asia now. So what we did was that orphan drugs, I'll skip orphan drugs. You already know that that's a drug which is used to treat patients with orphan disease. This is the subject that we are talking about now. So the question now is, what is the status of evidence synthesis for orphan drugs? Yeah. What we did is that we look into evidence available in Cochrane. Yeah. What are evidence available in Cochrane related to rare disease? So we look into evidence up to 2020. Yeah, up to 2020, there are, Cochrane is a worldwide renowned evidence synthesis pioneer. So this is actually an international standard for evidence synthesis. This is where people look at when they are looking for evidence. Yeah. I happen to be an author and also a trainer for Cochrane Malaysia. Okay. We extracted 331 systematic reviews, which I also called evidence piece, related to rare disease, and that included 1,181 trial reports, yeah, as of May 2020. What happened with that? First is that, first look at the evidence output in terms of what kind of disease they are talking about. Yeah, most of them, 39% of them talk about cystic fibrosis. Yeah, And then some are talking about thalassemia and sickle cell disease. Yeah? So these two diseases are very, very prevalent in the developing countries, yeah? And this is in developed countries. So this is more, together this is about 24% and this is 39%. Contributors are mostly coming from the UK and the USA. 5% from Malaysia, and quite a small number from other developing countries as well. Okay. Now, how about the quality of the evidence that we look at from the Cochrane piece of evidence that we have looked at? Yeah. The way you do that is that you need to see how many participants that they are able to recruit, yeah, for every trial, and then how many trials that actually are reported per evidence piece. Yeah. One here is that more than participants per evidence document, yeah, less than 100 is about 30% of them, and then about 100 until 1,000 is about 58% of that. Yeah. And only about 12% that recruit more than 1,000 participants. Yeah. And how many reported trials per evidence document here? Almost 50%, almost half of them only able to include 1 to 5 trials per evidence document. Yeah. And then this is also important. This is regarding quality of evidence. At the end of every systematic review, the authors are tasked to actually judge about the quality of the evidence that they have assessed. Yeah. 69% of the papers say they cannot decide, and 7% is very low. Only 3% of them say it's very high. Yeah. Are the outcomes meta-analyzed? Only less than half say yes. Yeah. Right. Okay, so that's the situation of evidence synthesis in terms of the rare disease. So there are still limitations in terms of where the papers are coming from. It may still be the Southeast Asian, the developing countries may still be underrepresented. Diseases, rare diseases, which are common in developing countries, are also underrepresented still. I'll move on to describing the rare disease situation in Malaysia and also in Southeast Asia. I took it from a publication in 2016, which compares between Philippines, Singapore, Malaysia, Indonesia, Vietnam, and Thailand. First, in terms of the infrastructure, expertise, and also policy. Yeah? Do we have patient registries? Yeah? Each country will have it, but largely institution-based. There is no such. There is very rarely we see a national kind of registry for rare disease, except probably for. I think for Malaysia we have a national registry for congenital anomalies, yeah, for birth defects. Malaysia has it. Presence of center of expertise, yes. Expertise are there, yeah, and they are based on many centers in each of the country, yes. But how about presence of national guidelines for treatment? As of 2016, none of these countries have no national guidelines. But actually later I will see it, Malaysia has just formulated in 2020 national guidelines for rare disease. For orphan drugs. I'm going to show you later. Yeah. Professional societies for specialty, meaning specialty that really that tackle specifically rare disease. Philippines, no. Singapore limited, Malaysia limited. There is none in Indonesia, Vietnam, and Thailand. How about national screening and financing in these 5 countries? Neonatal national screening programs, yes, all these countries has, except perhaps Indonesia. Percentage of newborn screened as the effect, then all the other countries have a good, relatively good number of percentage of newborn screened, except perhaps probably Indonesia. How about the source of payment for the newborn screening? Yeah, OOP is out of pocket, and I is insurance, G is government. Yeah, and here we see, amazingly, Vietnam and Thailand, the government pay for the newborn screening. Yeah, actually for Malaysia, it's kind of mixed, because there are a number of diseases which has been newborn screened, like G6PD deficiency, congenital hypothyroidism, which has been newborn screened since 1980 2003. That's paid by the government, but then when the government tries to expand that, then it becomes very difficult to cover that with the government. Yeah, so some of them are still out of pocket, and some of them are covered by the government. Yeah. All right, so there are challenges we already see. First is that there is false perception of being rare, which then makes it not a priority. Yeah? So this is a false perception, really. Second is there is low awareness. Yeah? Be it public and healthcare providers, so that makes the area of rare disease research and treatment underfunded, not properly funded. And then the drugs are also expensive. I would say some of the drugs are expensive, but not all of the drugs are expensive for rare disease. Some of the drugs which are new, like for SMA, spinal muscular atrophy just now, is extremely expensive. Yeah? And then expensive and uncertain diagnostics also makes it underdiagnosed. And there is also fragmented perspective. We tend not to see rare disease as one clinical entity. And in practicality, it's also very difficult to do that, because the problems are different. The characteristics of the disease is different. The need of the patients may also be different. Yeah? Then, and each would bring unique clinical problems and unique psychosocial problems. There's also stigmatization that this disease runs in the family. There's an opportunities there. One is that here, I mentioned earlier, in 2020, Malaysian government just published what we know as Malaysian Orphan Medicines Guidelines. This is product of many times of discussion between stakeholders in Malaysia. At the moment, Malaysia is also discussing in terms of expanding the national newborn screening. Yeah, next week there will be discussion on that, on how we can convince the government or what's the benefits, what's the advantage, disadvantage of including that, and which of the disorders which we should put into attention. So advocacy is very important. That really stressed the importance of advocacy. I took this from the statement of Winston Churchill, when he has something in mind and nobody else support him. What he says is that just keep buggering on, keep saying it, keep doing that, keep telling people to do that, right? And the next is that strategize for access to treatment. Yesterday, I had a little chat with a colleague, a speaker from Taiwan, who said that the drug for SMA was provided for free for their patients in Taiwan. It's funded by the government. So if they can do that, why countries like ASEAN countries, Indonesia, Malaysia, Thailand, Philippines, Vietnam, cannot do that with the existing national financing program that we have, right? In the later slide, I will say some. I will show you some comparison. And also, there is also one thing here is that China is able to reduce the cost for SMA treatment to very low because they are able to then put a case of volume. We have many number of patients, so if you if we use your treatment, then can you reduce the cost for each patient? So can we do that as well for ASEAN countries? Yeah, so that's why ASEAN societies should move as a united patient's voice. Okay, yeah, I have mentioned here, fight for inclusion in the healthcare coverage system. For Indonesian case, we call it BPJS. Okay, I'll try to make a case here. I'll try to compare between SMA, spinal muscular atrophy, and HIV. HIV, for HIV in Indonesia, the cost of treatment is covered by the national revenue, right? And it's free. It's not even by the national insurance scheme. It's covered by the national revenue. It's paid directly from the government's pocket. All right. How many registered patients we have for spinal muscular atrophy? Let's say we have 100 to 200. Okay. We still need to have more data about this, but this is more or less this number. HIV, 250,000 people are living with HIV in Indonesia. What's the treatment cost per patient per year in US dollar? For SMA, it's 375,000 to 750,000 US dollar. HIV is 1,000 US dollar. The total annual estimated costs for SMA that makes it 60 million. For HIV, it's 250 million. So it's a lot more here. How about behavioral risk factor? Okay, so now, if you are paying for a national insurance scheme coverage, would you want to cover, you are in fact actually also covering people who are committing risky behavior for them to contract the disease, drug abuse, sexual activity, risky sexual activities, smoking as well. There is always some moral questions there. Would you still want to actually do that? Would you are you aware that when you pay that, you're actually covering as well for them? Yeah, we don't have such behavioral risk factors in spinal muscular atrophy, but we have a substantial fraction of behavioral risk factors for HIV. But eventually, who pays the treatment here? It's the patient and HIV, the people who actually pay it, right? So this is something that we have to ponder, really, when we decide. Okay, that's it. Thank you very much.
Thank you very much, Prof. Teguh, for very insightful presentation. So coming to the discussion, I will invite all the speakers to be present on stage with me. Professor Damayanti, Prof. Retno Danarti, Dr. Kristy, and Prof. Teguh, please. And Dr. Shih is also present online. Dr. Seow is still also with us via Zoom. For the participant, upon asking, please mention your name and your affiliation, where you come from, and to whom as your question is directed. I will invite for the first 5 minutes for 3 questions. Is there any questions from the participants? Please.
Test. Okay. Assalamualaikum. A very good day. I have 3 questions for 3 of the speakers. My first question is to the third speaker, Dr. Kristy. I'm interested in what you presented on the exon skipping, and it is also a mechanism to alter the pre-mRNA splicing, if I'm not mistaken. So I would like you to, can you elaborate a bit more on the mechanism of the exon skipping? Because you say that it is also an RNA-based therapy, but also there are also several drugs that actually are involved in exon skipping. My second question is for Dr. Seow, the fourth speaker. I'm just curious, from the Singaporean government's projection, how much does Singapore actually could save from the precision medicine project? And if the project is not actually implemented right now, what is the projection of the losses in terms of economic, in terms of the economic point of view? And I would like to ask my dear Dr. Teguh, in one of your slides, you have shown that there is in most of the ASEAN countries, we have expertise on precision medicine. We have the expertise, but actually, what are the biggest challenges in actually for the institutions, the researchers, the clinicians to actually convince governments to actually hop on board the precision medicine train? Because in most cases, because in most cases, within the government, most of the politicians are not the brightest. So it is the biggest problem in most developing countries. I want your point of view. Thank you.
Sorry, could you please mention your name and from which university?
My name is Amin Abdurrahman. I'm from University of Science, Malaysia. Thank you.
Thank you. So I would address the first question to Dr. Kristy. Can you give comments on the mechanism of exon skipping more, and also several drugs working on it? Thank you.
Thank you for the questions. Yes, you are right that exon skipping is actually they do the works at the splice region. So it is an antisense oligonucleotide, consists of 20 to 30 nucleotides in length, and it is complement to the area in which you want to skip. So at the pre-mRNA level, the ASO, antisense oligonucleotide, attached to the area that you want to skip, and when the machinery comes, it cannot read that splicing site again, and it makes a new splicing site to make the out of frame into the in frame mutations. Maybe I hope you can understand. Thank you.
We will move to the second question to Dr. Xiu. Are you still there, Dr. Xiu? Yeah. The question for you is how much Singapore could save from this large project, and how is the projection? Could you comment on it?
Yeah, I want to say I don't have the answer as to how much we can save or we are projected to save, because we just sort of inserted the health economics element into phase 2. But I'll give you some examples of what is what can happen and what can come, right? For example, for familial hypercholesterolemia, 1 in 130 Singaporeans are expected to harbor that disease. If you start low-cost statins, you lower the cholesterol to normal, healthy individuals level. You prevent heart attacks. You save money in trying to address the heart condition, and when the patient suffers from a heart attack, all the resources that goes in, right? The second example would be pharmacogenomics. 30% of our hospitalizations in Singapore are due to adverse drug reactions. We found that in Singapore, Singaporeans harbor up to 4 genetic variants, which predisposes them to common to drug allergies, to 4 classes of common drugs, I think, and 30% of hospitalization. If you can prevent this and you implement pharmacogenomics and roll out whole of Singapore, you save money from these sort of emergencies, which are actually not necessary, right? Because we have the genomic information and we can predict and prevent and don't administer drugs that you're allergic to. My third example is the diagnostic odyssey for rare diseases or childhood diseases. It is estimated that the child who is suffering from rare diseases go through a diagnostic odyssey, for 5 to 8 years. Multiple tests, multiple MRIs, multiple scans. All these are money that you can save from the healthcare system if you had perhaps introduced genetic testing much earlier on in the clinical workflow, rather than after 8 years of trying and failing repeatedly, then you introduce genetic testing. So I don't have the specific numbers now. My government is going to ask me for those numbers too. We are working very hard. I may not have the full picture of how much exactly, but we can provide snippets and perhaps, evidence to move things in the right direction to show that we are not threatening, right? We want to help and we can help. Over.
Thank you, Dr. Seow. Very interesting. And I will move to Prof. Teguh. What is the biggest challenge to convince the government? I think this is everybody's problem. I think it happens in every country. So can you give some comments or view on that?
Yeah, there are 2 things. One is that we have to admit, we all have interests. Each of us have interests. We as students have interests. They as researchers have interests. We as politicians and government have their interests, have their own mind, have their own idea about what to do in the next election, to do in the next batch of my rats, for example, for researchers. And the challenge for researchers is then how we can actually some for our politicians who can give them a quick win that they can easily and quickly bring to the attention of the media, for example, that they have win something from what you have done. So that's the thing. So then they have something for their next election. Yeah. So that's the idea, and I believe that's also the reason why such big project like what happened in Singapore with SG 100K, and also in Indonesia now have also the preliminary stage. Have the preliminary stage, and the end of the preliminary stage happened to be at the election, right? Because at the end of the election, then you have to really make your case. Is it something worthwhile? Is it something that can save money, right? But there is another issue with that, yeah. If we go into that area, then we also have to be able to show that the issue that you bring up is an issue that people care about. Yeah, like if you go to rural Indonesia and you go to rural Malaysia, for example, and you ask people there about precision medicine, they might just look at you clueless. Yeah. So now, so this is again delineating the importance of raising awareness, yeah, advocacy in every layer of the populations, from the general public up into the probably government officials, politicians, and even also the healthcare providers. Yeah? So then part of the tasks of researchers is also actually raising awareness. Right? That's my answer. Thank you.
Very interesting, Prof. Teguh. Yeah, please, Prof. Gunadi.
Thank you very much, Dr. Mira. I have a question to Prof. Damayanti, that we already know that you have such great experiences to taking care of children with rare disease. Then what do you think should be applied to particularly not only the vertical hospital but also the district hospital, because I think one of the most challenges is referral system in our hospital. So what is your suggestion then to not delay the patient come to the most appropriate hospital? And that's the first question. And from Dr. Siwe, thank you for joining us. For Dr. Siwe, I think we do believe that Singapore is advanced in genomic technology, and we do hope we can leapfrog to your country. We do hope. And my question to Dr. Siwe, that during your role guiding, assisting the development of precision medicine in Singapore, how do you expect, what is your suggestion to us Indonesian, that we just start last year August, and our Ministry of Health asked us, the hospital, the hub, to be finished 2024, the October, and the genomic of human being from Indonesian population should be finished approximately 10,000 human genome. Is it based on your experience? And Prof. Retno Danarti, I think interesting from following the answer from Dr. Siwe for the previous question. Do you have any idea how much we can save for genetic disease if the genetic or genomic technology included in the management of genetic skin disease in Indonesia particularly? Thank you.
Thank you, Prof. Gunadi, for your questions. I think directly from Prof. Damayanti, could you please comment?
Okay, thank you, Professor Gunadi. I think is first, the diagnosis is important. Yeah, I think you are all here is student, medical student, mostly. Yeah? I think some of them is not, but mostly is medical student, and you will work with patient. What you should do is you make a diagnosis is important. So who make the diagnosis is the doctor. If the student didn't know what is the rare disease, for example, then every area is different. For example, I give the lecture from the first grade medical student, an example is for the lysosomal storage disease, because that's the very easy to diagnosis, and he can look again, then you can expect it that is possibly is the rare disease. And you know, one of my students find the disease when he works as intern doctor, yeah? And they send it, they call me, Prof, this is your patient that I remember that you give the lecture of this patient, And then I think I found it. Okay, just send it. He sent me email that time. Just send it the picture. And then I told them, I think you have to look at my another lecture. Do you still have my lecture? Yes, then they, yes, I know, doc. Okay, just bring it. Where's your place? Then he bring it the patient. Then I'm so proud of them because two pediatrician who taking care of this patient before didn't know about this. But my student, yeah, after several years, they can make a diagnosis. Now, it's more doctor could make a diagnosis. I get the consultation from the small island in Jakarta, in Rio, and small island in Papua and everything. Then this is the first time that you should know, and the university should teach the student from the beginning. But what kind of disease, the kind of disease that is already diagnosis, yeah? The second, then you have to work with the disease that already have a treatment, and the treatment is available. Yeah, you cannot say that is you make a priority with the disease that is no treatment at all. Yeah, the government, not even the politician will interested with that. Yeah, even I'm talking to you because this is my experience, how I work on the simple treatment with the milk, you see the formula, that is simple, relatively cheaper, but how long I work with the government? 15 years to make them. Now it's still in the way. Yeah, I don't know, I hope this year they can sign it, then you can get it from national insurance. If they have already confirmed like this, then you can begin with screening. So not at what you think that, okay, I would like to be like this and government should pay for that. No, it's not like that. Yeah, but just begin with the one disease, then you will fight what the treatment for your patient and working with your heart. Yeah, not only with brain, but with your heart. Then, you know, I get the treatment, sometimes I lost 10 patients first because they have already died, but the treatment is not yet available in Indonesia. But now, we can have the treatment for the patient, even though that's via a donation, for example. But people will give you donation if they see that you can treat the patient. So this is not a very nice story, what is the easy story, but it's difficult. But with your heart, you want to help. I think all the doctor would like to help the patient, yeah? With that idea, I thought you can help them. Yeah, this is what my experience to do in Indonesia. With 10,000, at least I have the confirmation of 400 disease. Then not only the diagnosis, but we treat the patient. Yeah, treat the patient. That could be definitive, but could be also supportive. And we work in the team. And we also ask for other university to build the same treatment, yeah, all over. So every part of Indonesia should be treated well, even though the disease is rare. Because I don't know how long when the government will see this kind of disease. Maybe this is what I would like to say, Dr. Gunadi.
Very insightful, Prof. Damayanti. So the teamwork and work with your heart to help the patients. Move forward to Dr. Shih. Could you please give a comment on your suggestion to us? To start, we have already started just last year. Do you want to give like suggestion or comments, please?
Yeah. Thanks, Prof. Also, thanks, Moderator. I won't say suggestions, but perhaps my experience from the Singapore program and having been almost there from the start, I have three sort of key learnings from our own experiences. First is extensive stakeholder engagement. We make sure that it's a whole of ecosystem involvement, so nobody feels left out, everybody feels involved. We share our ideas with them, we get buy-in, we consult with them, so that when the time comes and we need their help, they feel like, yes, we did contribute to this. So it was very deliberate. And at that time, for phase one, to sequence 10,000, it needed significant, research investments from the government. It was one of the larger programs. So we needed to do a lot of convincing as well, to move things to this stage where the Ministry of Health is actually interested and actually sits up to sort of, listen to us from time to time. It took a lot of stakeholder engagement. And obviously then also the staged approach helped us as well. We didn't go in and say we want to sequence 1 million from the very beginning. We said we will start small, we demonstrate the quick wins, gain the trust from our ecosystem partners, gain the trust from our government. Then we ask for more money to continue. And again, each time we ask for more money to continue the program, we demonstrate or at least project to them what are some of the potential delta or increments that can be made. It should not be the same as phase one, just increase in scale, but there should be other elements and KPIs that can be achieved or hit as a result of this additional funding. My third observation is, whether or not to buy, to build in-house or to partner with commercial companies. Certainly because we are government funded and we are in a way, government related, we certainly don't move as fast as the private sector. We did try initially in phase one to ascertain whether we should create in-house and sequence, buy sequences and do it in-house. But then, we consulted with various stakeholders, or we heard from the ground, there are actually existing companies that can do it. So there was no need for us as a research program to invest in the sequences. We partner, or in that instance, we buy the service. Yeah, so these things to see, what makes most sense to help you progress to the next milestone that you need. So yeah, I have three sort of observations from my own experience. I wouldn't dare say it's advice, but really those are my experiences. Stakeholder engagement, staged approach, and also to consider whether to buy, build, or partner. Over.
Very interesting, Dr. Shih. Thank you. Before moving to the question from participant online, I would like to give Professor Retno to make a comment on how genetic analysis can save or can be beneficial for the genetic.
Thank you very much, Dr. Gunadi. In my presentation, I highlighted the importance of clinical diagnosis, and Dr. Gunadi, Prof. Teguh has highlighted the importance of the genetic analysis, and when the treatment is follow the diagnosis, right? Yeah, and with the diagnosis is secure, the diagnosis is confirmed, is definite diagnosis is confirmed, we can early treatment. And unfortunately, many genetic diseases have no treatment, but we can still do something with the counseling genetic. Yeah. Thank you.
And even though there is no treatment, definitive treatment, it doesn't mean that we cannot do something. Yeah. We can make this life of this patient is easy. Yeah. Make a supportive treatment, what we call it. Yeah.
Yeah. We educate and make counseling and yeah. Thank you.
Thank you, Prof. Retno and Prof. Damayanti for the comments. We will move to the question from.
I have one question.
Oh, sorry. Yeah.
Okay,
Yeah.
Okay, thank you to all the panels. I am Nurul Huda Binti Musa from University Putra, Malaysia. I have two questions. Number one, I would like to ask Prof. Damayanti. So I'm impressed with the progress made in addressing rare disease in Indonesia. So the journey from your initial journey until up to the changes in the tax policy with the tax exemptions, I think it's a remarkable success. So I have a question regarding the coordinations of rare disease in Indonesia as a nationwide with a large number of island and also large number of populations, how the rare disease is coordinated in Indonesia. Is that like hospital have to report to one center? That is my question. So my second question to Dr. Teguh. I would like to have your perspective because you have both feet in Malaysia and Indonesia. So I want to hear your point of view on the movement of rare disease organizations in Malaysia. What stage are we now? Because is there any network or movement that coordinate the rare disease in Malaysia? I'm not sure if there is any because that's something that I'm not aware of. So it's always a dream to have a one center of a rare disease that collected all the data in all countries. And let's say, because as you mentioned, rare disease is always underdiagnosed. Not all clinicians can diagnose the rare disease. Because we have experience with our patients also, they have to go to 3 hospitals until can be correctly diagnosed with the disease. So that I think makes some of the patients with the rare disease being, they are not, I mean like if they go to the hospitals, go back, clinicians cannot diagnose, so probably they will just live with the disease without being diagnosed. So it's always a dream. If we have one center, so all the clinicians, all the geneticists can gather and report if there is any cases that cannot be diagnosed. Because we have experience attached in Istanbul, Turkey. So they have a undiagnosed and rare disease center that the hospital can give the data, that they gather all the bioinformaticians, clinicians, geneticists, even the service provider. So when they encounter any undiagnosed, because they have quite a number of rare disease because of the consanguineous marriage, so they will report to the one center. So they will gather as a whole all the main player like clinicians, they will diagnose the cases. So in Malaysia, as I know, we are work in isolated. So I would like to know, is there or in future that, because Prof. Damayanti said someone has to start. So I would like to hear your point of view if in future we will have this kind of center. Thank you.
Thank you for your question. Please, Prof. Damayanti first.
Yeah, thank you for your question. Yeah, but you know, the first time Indonesia is 17,000 island, but the main island is about 6,000. Yeah, 6,000 is main island, the biggest island. So what I would like to say, this is the one that that's in my mind. I only want in the hospital in the capital of Jakarta. I don't know how I get this patient all over Indonesia. So first awareness, go to the government, what they say, oh, we have a lot of infection. I don't care about the rare disease. So we are stopped? No, because they are there. Yeah, but they don't know that there's no brand is the head of the patient. I'm rare disease. No, you have make the diagnosis. Then what you should do, that's important to teach the doctor to know what is the rare disease is. So I give the lecture in the first grade, yeah, when you learn about the cell and genetic, you remember maybe, you learn the first time, then I give the background disease, why you have to learn this. Then this is the first time we introduce this to the rare disease. Because mostly the genetic disease is rare disease. Yeah, but you, in the first time, you learn how it's working, the pathophysiology and anything. And second, every year, every grade, I give the lecture. And then I came to the organization profession. You know that because the 60% of the rare disease is diagnosis when this is in the pediatrics age. So I go to the National Pediatric Society. So I become one of the field there. So I can give the knowledge and give the education to the doctor from all over university. So they came to me to become my fellow. Now I have the fellow from the Aceh until the Manado, but we don't have yet in the Nusa Tenggara and also the Papua. Yeah, but at least every island, the biggest hospital, they have somebody who understand about the disease. So we make a system that I have already mentioned to you that I have every Friday, I open the diagnostic day. So this is with the, before Zoom is now, we use the Skype. So they make if they have a patient, they can make a presentation and we work together. I said not because I'm the most people know, because we can learn together. Yeah, so we can learn together. Sometimes my students have an idea. Maybe this one doc, when I read, this is the possibility of this diagnosis. And we look again, and sometimes we make contact with the the expert outside. Yeah, so we discuss. That some of my colleagues also from Malaysia, yes, several of my colleagues come from Malaysia, and sometimes they help me with the facility they have in the Malaysia, in university, in the Negara, yeah, Laboratorium Negara. You know, sometimes I have a friends with the Taiwan, so they examine some patient there for free. Some of company will pay for something. That's something you can build. Yeah, you ask the government? No. They don't care about the patient. I can talk like this because 20 years I'm fight for this child. Because as a doctor, they sit in front of us. And we know exactly that we can help them, but the patient cannot pay. But if government give the insurance only a little bit for them, they can give it. But they don't want to give it because still waiting with the excuse the same, the infection is high and a lot of patient with another most common disease, something like that. But just what I said first, just do it, give a treatment and give diagnosis, but the treatment cannot do if you don't make a diagnosis. And diagnosis could help by the crowdfunding if too expensive. Yeah, but if you know that it's treatable, then treatment is available and do it. And that's what I'm doing now. Yeah, so maybe I'm still fighting with the government, but I think I'll try to do it without government. Because we are a doctor, we should help our patient.
Very important.
Yeah, it is what I would like to share with you. But you also, I think, because I have a patient, I have a lot of friends. Because one is what Malaysia is have benefit, because you have a lot of geneticists that have the education in English or Australia or US, but in Indonesia only me. Until now, even for education, they don't send geneticists abroad. Yeah, but I don't care. I teach them by myself. I said, yeah, yeah.
Very
so
important.
that's what we have to know. We have to be. It is something that you cannot teach. Your heart, yeah, how you can help people, then how can spread your knowledge. That's it is what we are doing now in Indonesia, because Indonesia everything is difficult. But it doesn't mean that we cannot treat the patient. Yeah.
Very insightful, Prof. Damayanti. So make a system and work together and go through it. Fighting for the government. If the government doesn't give the funding, then we will find another funding.
Yeah.
Yeah. Right.
Don't care about, you know, that's our patient.
Right.
In front of us, not in front of government.
Right.
Yeah.
Right. Thank you very much. Dr. Teguh, Prof. Teguh, please.
We are now listening to a prayer calls for Muslims.
Yeah.
So let's take some time for
Yes.
that.
Yes.
Yeah.
Could you please give a short comment because the time is approaching?
Oh, sure. Okay.
Thank you.
Okay. All right. Okay. Thanks, Huda, for the question. Okay. I think what I can share with you is some of the parameters. What do we have to do in order to be at that stage for in terms of rare disease? One is that I have shared it in one of my slides. One is that at least we have to have a patient registry, and that has to be national and curated patient registry for rare disease. Yeah, and then second is we have to have a center for treatment where expertise are working there. Yeah, experts are working there. Center of expertise where patients are being treated for at least for the what I mentioned, the 72% most common rare diseases. And then do we have national guidelines for treatment for rare disease? Yeah, and then is there specific societies like we know now we do have for example pediatric association, for example, or internal medicine association. which among others probably within their branches, within their chapters, they have chapters or sections that are handling rare disease. We probably have to have societies, specific societies that develop its own expertise on handling rare disease itself. Yeah, and then national neonatal screening program. Yeah, national neonatal screening program or newborn screening program. It's not something easy to develop. It's not only about funding from the government. It's not about buy-in from the government only, but also in terms of acceptance of the public. Yeah, you can imagine during COVID, how many people actually reject vaccinations. So now, with the newborn screening, how many will actually give their newborns blood to be tested routinely for every birth? For what is this purpose? And so on. We have to convince the people for that. And then finally, the money. Where would the money come from? As long as the money come from the people, then we are still backward, right? So so I'll tell you here is that even there is a misperception about that genetic diagnosis, genetic test is expensive. Well, actually, a cost for example, SMA, spinal muscular atrophy, which require only PCR-based technique, is actually very cheap. Actually, very cheap. And I don't find the argument why it's actually not included in the insurance coverage or in the national health system in Malaysia, for example. People in Malaysia have to pay themselves. People in Indonesia have still to pay themselves. Why it's not even included there? We can understand if it's involving whole genome sequencing, for example. But this is a simple PCR-based technique, right? Mm-hmm. Right. Okay, that's it. And you're right. Common platform is important. Common platform have some challenges as well. When you see here, when people start working together, then people start measuring each other. Where are we? Where they are, and so on. And people here we have to really ensure trusts are there between among the players when we work together. Mm-hmm. But yes, we do have we should have common platforms. And which platforms are there? We do have societies in each country which should be able to work together. And you yourself, as students, now you are sitting in the common platform that join together ASEAN students at least, and even students from European. You can start working together. 20 years ago, I was in this room. At that time, in 2000, Prof. Sunarto established bioethics, the first in the country. I was a student. I was among a few students there. What we did is that we suggest a declaration of students in Indonesia that we need bioethics for our education. It's still there now. Mm-hmm. Yeah? Now, as a student, what you think you need to see when you are in practice in terms of rare disease? What do you want to see when you are in practice in terms of rare disease? What do you want your patients to receive when you are in practice?
It starts from us
yeah,
now.
That's right. Correct. Thank you.
Thank you. Thank you, Prof. Teguh. I will give one short question from online participant. Only one, please. Can you give me one question for Dr. Seow? I think it's very difficult to interpret the data, and I'm just curious on how you can involve individuals from different genetic backgrounds and how they can be included in the Singapore National Project. Dr. Seow, please give a comment on this, a very short comment, because we are almost at the end of the panel. Are you with us, Dr. Seow? Thank you.
Yeah.
Could you please give? comment.
Yeah, thanks, Ezra. It is true. Admixture, we find that it's getting increasingly common in Singapore. I just checked the statistics, 16.6% of our marriages in Singapore are intermarriages. So between races, if you may. For the 10,000 cohort that we studied and enrolled, we actually find that a lot of the self-reported Chinese have an element of sort of Malay blood in them. And then the Indian, self-reported Indian ethnic participants actually have some element of Malay blood in them. So what you have raised is actually very valid. Unfortunately for now, so the reason why maybe they have self-declared themselves to be Chinese is because perhaps also of the way we use reports about race in the national identity card. Only one race, so you are either a Chinese, a Malay, or an Indian. We don't usually say I'm Chinese Indian. So maybe that's why the sub admixture is not reported or picked up in or self-reported. But yeah, it is increasingly relevant. But at this juncture, the program focuses mainly on three ethnic groups: Chinese, Indian, and Malay. As the genomic tools for admixture analysis becomes improved, we are certainly looking at it for phase 3 onwards. Yeah, I hope that helps.
Thank you, Dr. Shosiwe. Unfortunately, the time is up, and we come to the end of this panel. And summarizing from all the speakers, learning from all the speakers, we all know that precision medicine is important in diagnosing and treating the rare diseases. And we all keep convincing our government, and we learn from our neighboring countries, from Singapore, from Malaysia, to keep moving forward to help our patients and communities with precision medicine. I thank you very much for all the speakers for outstanding talks, and all the participants for the very fruitful discussion. And good afternoon. We will continue after lunch. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, so guys, just for information, you have a lunch break until